Today marks our fifth in a series of press briefings we've offered on the business and economic ramifications of COVID-19. Today's focus will be on the impact of the virus on healthcare systems, supply chains, providers, and patients. So very excited to have you with us for this important conversation. And before we kick things off, I'll walk you through a bit about the way today's conversation will go. We've got with us 5 experts today, which is fantastic, each with a really unique perspective and a set of insights to share on this topic. So we're going to spend the first half of today's webinar with each of them sharing some findings from their research and notes from their own areas of expertise before handing things over to you, the reporters. For the second half of the call, we'll open things up for Q&A. For reporters who are joining us today via webinar, you can submit your questions anytime using the Q&A function at the bottom of your screen. I will be moderating the second half of the call as all of our participants are muted for the duration of today's webinar. For those who are joining us by phone, you are welcome to submit your questions to me via email. You've all heard from me plenty, but as a reminder, my email address is mackenzie_bad@keenan-flagler.unc.edu. And again, you're welcome to submit those anytime during today's webinar. So with that, it's my pleasure to hand things over to UNC Kenan-Flagler Business School professor and faculty director of the UNC Center for the Business of Health, Brad Stotts. Brad?
Appreciate the chance to be with you all today and to share with you some thoughts on testing. As of yesterday, April 13th, reported data shows 2.9 million tests have been completed in the United States, of which 63,000 of those have been completed in North Carolina. Unfortunately, testing has ramped up much slower in the U.S. than one would have hoped. These numbers are much lower than ideal at this point in the crisis and lower than what we'll need in order to effectively reopen the economy. The question becomes, why isn't the value higher and what can be done to improve it? When we're talking about testing to date, what we're really talking about is PCR, polymerase chain reaction assay, that finds tiny amounts of the SARS-CoV-2 genome in, say, a nose swab. The process relies on finding the active virus. Now, we have to look at kind of why have we seen these bottlenecks and what's happened over time. And it's actually changed over time. So initially, the challenge was simply in having a test. The CDC developed and shipped the first test to receive an emergency use authorization from the FDA here in the US, but it was subsequently revealed that there was a flaw in the design. And in the ensuing weeks of February, they had to work through this, eventually solving that problem, and the FDA worked to approve other tests. Recognizing the inherent challenge a regulatory body like the FDA faces, they want to move fast, but they need to validate that tests work. It's in no one's interest to conduct millions of ineffective tests. As of April 13th, there are now 32 PCR tests that have received the authorization, 10 laboratory-developed tests, including one here at UNC Health. And tests have scaled across numerous locations, so the existence of tests is no longer an issue. But there are a number of critical bottlenecks that still exist. The first comes in maintaining sufficient materials to conduct tests. This shows up in a few ways. One are the test kits. Mechanisms simply to acquire the sample, typically a nasopharyngeal swab. Sometimes you call it an NP swab, right? Kind of looking at what you stick inside somebody's nose. The actual collection mechanism, the tube, these are very simple materials, but having produced enough has been a challenge because no one expected this huge spike in demand. In addition, need the reagents to run the tests. Different enzymes are needed for these. These are biological molecules, usually produced in bacteria at small volumes. And so again, suddenly, there's demand for significantly more volume. With both tests and kits, these are real issues because facilities have been shut down, shipping is sometimes slow, and so working through the supply chain has been a real issue. The third piece is personnel and equipment, and these have been binding constraints in some places, but not everywhere and not as problematic as test kits and reagents. The second bottleneck has been the geographic distribution of testing. Actual samples have to be tested. The test itself runs in a short time, typically hours, but the sample has to be collected, taken to a lab, meaning it may be days or even longer with backlogs. Often this is local, but as outbreaks occur in different parts of the country, then with labs there may be overwhelmed. Ideally, labs at capacity would stop taking samples, but in places like California, Quest Diagnostics suffered extreme backlogs due to the demand spike, even though capacity might have existed elsewhere in the state or certainly the country. Hospital systems have also had issues with having contracts in place or even having their electronic medical records sync up correctly. As we move forward, how do we scale testing capacity? Well, there are a few things to do. First, bottlenecks with sourcing of test kits, reagents, spreading out the demand across technology interfaces will continue to be key. Second, an important question is around reimbursements. Tests are incredibly valuable as they help us understand who's infected and permit us to isolate those individuals. However, current Medicare reimbursement is slightly under $36 for the CDC's test and only $51 for non-CDC tests. There are good reasons to suggest these values should be much higher to encourage more investment in growth and testing capacity. Third, ongoing innovation is key as serological tests are developed and deployed. A serologic test isn't for diagnosing, it can detect antibodies in the human to know if someone had the virus. This will be key as we seek to understand how widespread infection was and how long immunity to COVID-19 might last. Finally, we need to continue to improve the quality of our tests and, most importantly, our sample acquisition. There's too little published data about the revealed quality of our current tests. The underlying science of PCR is high quality, but reports suggest too many false positives, perhaps due to sample collection. We need to continue to work to improve this so we can trust our tests, but also build robust protocols when tests might fail. Until we have vaccines and antivirals, testing is going to be key to contain and help us eventually reopen the economy, and more work is needed to support this process. Happy to share with you on testing. Very eager to introduce my colleague, Jay Swaminathan, to share more on the supply chain.
Great, thank you, Brad, and good morning to all of you. I have been studying supply chains for over 2 decades in non-medical and medical fields, and I'm here to share some of my insights around why we are seeing what we are seeing today in terms of PPE shortages and other types of shortages in the healthcare supply chain, and what can we do about it. So first of all, let me begin by telling you a little bit about what this type of pandemic risk means from a supply chain standpoint. We typically think of supply chain risks to be of different types. This is what we call as a right-tailed type of risk, which means it's very low in frequency, but very high in impact. And so what that means from a supply chain standpoint is that we have to think about this risk from a different perspective than other types of risks, such as a machine breakdown or a worker strike. So what are some of the things that people or corporations or organizations tend to do when facing such risk, and how do they typically respond to those? Typically, there are 4 main strategies that we use as we are thinking about these types of pandemic risks and the mitigations around it. First is respond very, very quickly. Second is having stockpiles of strategic items and then centralizing and controlling them. Third is being very responsive. That means reducing the lead time to get the products that we need. And then finally, being able to ramp up the capacity and inventory around these items. Now, let me tell you a little bit about how this has gone in terms of the COVID crisis here in the US. First of all, I think in terms of response, we all know we were a little bit late in terms of realizing that this was a pandemic and then getting the supply chain ramped up for that. Secondly, we had very little strategic stockpiles, and even the ones that we had, such as the millions of masks in California, we're not careful in monitoring that inventory and didn't realize they had already expired in terms of usage. So that was limited. And then over the last 2 decades, we've had a dramatic increase in the amount of globalization in supply chains, and healthcare is no exception. So that globalization with having suppliers far away from us, far away from the United States, is hurting us today. And finally, we didn't think about alternative sourcing. That means ramping up other facilities as quickly as we should have. And this is the reason why we find ourselves in the position that we do in terms of hospitals, in terms of shortages, in terms of PPEs, masks, gowns, and even to some extent ventilators, right? So what can we do at this point, right? There are a few strategies that one could use. The silver lining here is, at least in the US, we seem to be getting to those strategies faster than we were in terms of the early response. The first one relates to alternative sourcing that is closer to home rather than relying on expanded global supply chain. And this is where you see an example where Flextronics, a major supplier of Apple, is likely to start making face shields, right? Another way to expand capacity and ramp up is ramp up the production existing plants, and this is beginning to happen now in plants in the U.S. We also need to, a very important piece of all this, we need to be able to use our scarce resources more effectively in this period. In our past research, we have found that oftentimes when resources are scarce, many hospitals and many clinics and many entities tend to distribute them on a first come, first serve basis. That means the first person who comes in gets to use that. It is quite possible in a few months' time we are going to, if this does not, reduce in scale, we're going to have good policies in terms of how we allocate resources, particularly ventilators and ICU beds. And here's where some logical thinking and optimization around how we treat patients can have a big impact on the overall efficacy of our approaches. And last but not the least, we also see that we want to use the technological innovations in place, and it's really heartening to see some of the companies both in Massachusetts and nearby in South Carolina coming up with usage of 3D printing technology to expand capacity on existing ventilators. So you can actually take a ventilator and then create those walls that enable you to support more than one patient at a time. And so, having alternative sourcing closer to home, expanding capacity in existing plants, better allocation of resources, and also technological innovations are ways that we can catch up and do as well as we could at this point in time. Now, as I said, many of these things are beginning to happen in the US in response to the COVID supply chain. So I'm pretty optimistic about what's happening, but things are not going to change overnight. So the key is we need to have a little bit of patience, and I know this is an effect that is going to happen, but it might take a month or two before we see the effects of these initiatives. With that, I'm going to hand it over to my colleague, Vinayak Deshpande, who's going to talk about some of the specifics related to PPE shortages and what we could do about it.
Good morning, everyone. As Jay said, I'm Vinayak Deshpande, and I'm a professor of operations here. Can you all hear me now? Good. Okay, great. And I'm going to talk a little bit about healthcare supply chains, adding a little bit more color to what Jay just talked about, and talk a little bit about what might be some potential solutions, particularly for the PPE shortages. So that's going to be a brief outline of what I'm going to talk about. So if you look at healthcare product supply chains, there's typically about, I think about 2 years back, $456 billion spent on healthcare products. And typically these products are classified into three categories: pharmaceutical products like drugs, med-surg supplies, and devices. And if you look at these healthcare product supply chains, essentially there are four major players: the manufacturers of these products, the distributors of these products, the hospitals and pharmacies and retailers who are at the bottom of this supply chain. But also typically another entity that's not typically talked about is a GPO, or a group purchasing organization, who typically negotiates contracts and purchases on behalf of member hospitals with manufacturers. So these are the primary entities in the healthcare supply chain. And if you look at how much inventory these different entities carry of these products, typically a manufacturer may carry from somewhere from 3 to 6 months of inventory. So if you look at manufacturers of either med-surg products or drugs, during normal operations, they typically carry somewhere from 3 to 6 months of inventory. Distributors may be carrying about 1 to 2 months inventory. The GPOs themselves don't carry any inventory, and hospitals have recently decided to go lean. Many of those hospitals have embraced lean ideas, so the amount of safety inventory isn't that large at hospitals. So if you look at the split of inventory, that inventory typically is carried primarily at the manufacturing stage in the supply chain, not much at the forward locations in this supply chain. And one of the consequences of that is that these inventories are typically carried based on normal usage, but the situation that we have right now is a situation of crisis where demand has suddenly just shot up. And as a result, those inventories are really low. So just to give some comments on the structure of the healthcare supply chains, the healthcare market for healthcare products is highly fragmented. There are thousands of hospitals, and as a result of that, information about inventory is not really transparent. So it's hard to figure out who has how much inventory of these healthcare products. Another point to note here is supply chain management is usually of not strategic importance to hospitals. So for example, strategic sourcing was probably not on the radar screen of many hospital CEOs. So that's another thing to note. So that potentially could have led to shortages of PPEs. So the country, for example, as Jay mentioned, has a stockpile of about 30 million N95 masks, but we probably need many more than that, much more supply than that. So the CDC, what it does is it has 3 modes of operation that it highlights: conventional, contingency, and crisis. So currently, CDC recommends all US healthcare facilities should begin PPE contingency strategies right now. Those contingency strategies could include things like engineering controls, administrative controls, canceling elective and non-urgent procedures, and so on. And it has also recommended that those healthcare facilities which are experiencing PPE shortages to start considering crisis capacity strategies. So there was a very nice article published in the JAMA Medicine, which kind of tried to look at the PPE shortages and summarized all of those ideas. So what I'm going to do is briefly summarize some of these ideas for sourcing PPE during the COVID-19 crisis. These ideas fall along 5 different categories. One idea is to reclaim, procure PPE from existing sources. Another one is to reuse used PPEs. A third one is to create supply from available materials. A fourth one is to extend supply by repurposing existing equipment. And a fifth one is to conserve the use of existing PPE that we have. So I'll give you some examples of each one of these. So an example of reclaiming or procuring from existing sources is that healthcare is not the only source of PPEs. There are many other industries such as construction, manufacturing, research labs, vets, farms, and so on that have supply of PPEs. So maybe one way to reduce the shortages of PPEs in healthcare is to start procuring from these other existing sources of supply. A second way is to reuse used PPEs. So there have been numerous proposals that suggest sterilization of used PPEs. And there have been some really novel proposals of what agents should be used for sterilization. And a number of hospitals are currently pursuing these strategies, including the UNC hospital over here. A third strategy is to create supply from supplies that we already have. So for example, using filters from air conditioning or vacuum cleaner bags. So if you look at N95 respirators, those are 95% efficient for 0.3 micron particles. And that's equivalent to a MERV 16 filter, which is used in HVAC settings. So one suggestion has been to, for example, use some of these filters that are already available in air conditioning and vacuum systems and create masks out of those supplies. A fourth strategy could be to extend supply by repurposing existing equipment in various industries. So for example, there are various commercially available devices used in the welding industry, which could potentially be used as a PPE in healthcare. There are positive air pressure helmets. So there are many such equipment that is available that could be used in healthcare settings too. And finally, a fifth strategy to conserve the use of existing PPEs by suspending practices that consume large amounts of PPE. The idea of using healthcare workers who have already recovered from critical illness and who now are presumed to be immune, and as a result may not require the use of PPEs. So these are kind of the 5 different categories of ideas that have been proposed to alleviate some of the shortages on the PPE. Of course, there are many other ideas too, But eventually, in the long term, we are going to need solutions like increasing domestic production capacity or adding flexible capacity. But one thing I also like to highlight that we need better information systems to track the supply of PPE inventory in the healthcare supply chain. So on that note, I'm going to pass it on to Cheryl, who will share some of her comments.
Thank you very much. It's great to be here with you this morning and talk a little bit about, excuse me, the health workforce and what we might do to address some of the needs in the health workforce. My name is Cheryl Jones. I'm a professor and workforce researcher in the UNC Chapel Hill School of Nursing. I want to put my comments in context of three main things. First, to prevent and reduce the number of COVID cases in the general population. We've all heard about this, the testing, we know this, but if we don't take this step, hospitals and other healthcare settings can quickly become overwhelmed. The second theme is caring for those who have COVID as well as those other patients who are sick. If we don't do this, we could actually experience avoidable deaths and maybe even greater avoidable deaths than we've already experienced. The third is to provide and protect the healthcare workforce so that they can both care for patients and help prevent the spread of COVID. If we don't do this, we will have staff getting sick, burning out. We've read a lot about and heard a lot about staff burnout. I read a statistic recently that 3 in 5 nurses want to leave their jobs. So there's a fear of losses to the workforce, people calling in sick for work, but either because they themselves are sick or because they need childcare. Another related issue in the workforce, health workforce, is that like the population, the healthcare workforce is aging. And we all know that those who, as individuals age, they're more vulnerable to the COVID. So nurses are in a particularly vulnerable position because they have such close proximity, physical proximity to patients, and they're with patients 24/7. So all of these issues are interacting to affect the supply of the healthcare workforce when when we actually need them the most. So what are some solutions? Obviously, to prevent or reduce the number of COVID cases, society, the government, and individuals have to take actions to prevent, reduce the spread of COVID. These are things like washing your hands and social distancing and things like that. I'm not going to dwell there, but that's a really important message. Another solution is, in order to care for COVID patients and other sick patients, we need to take reasonable and safe steps to increase the availability of the healthcare workforce. And I'm going to offer a few strategies. First, there are qualified people who want to work and to help, but they can't. So some of the strategies that could help address that particular issue would be things like relaxing or waiving practice restrictions and regulations. For example, waive the requirement that nurse practitioners and physician assistants have to have a sponsoring physician. That particular issue has gotten a lot of attention. There could also be restrictions loosened around the mobility of individuals from one state to another and getting quickly licensed in a state or where nurses and other health professionals might be able to travel. Another problem has been the visa limitations and the travel bans, so that people who want to travel can actually travel to other states and locations. So there are some issues around, from a regulatory standpoint, around visa limitations and travel bans that, if relaxed, could actually help bring people into the workforce. There are some other issues that might actually help to increase the number of, especially intensive care nurses and intensive care staff. I'm sure everyone has heard about the need for more ICU staff. One of those issues is to train non-ICU nurses and staff to work in ICUs. that's great. And there are many staff who are willing to do that. But that only goes so far because the patients in those areas they're leaving still need care. So it's almost like a shell game. Another strategy is to engage students. I will tell you, as an educator, students really want to help. They have a moral commitment to caring for patients, and they are very socially conscious. So those students who are near graduation, in many cases, may not be able to take the licensure exam because of the limitations of social distancing, where the testing stations have to reduce the number of candidates they can test at any one time. So there are issues around the licensing exam and students being able to sit for the licensing exam. Some states are actually considering things like allowing new graduate nurses to practice as a graduate nurse even prior to sitting for the license exam. Other students who are not at the point of graduating, but who have had some of their fundamental courses could also serve as nursing assistants or be fast-tracked to be nursing assistants so that they can help out on patient care units. There are other things that organizations and society can do to help get the workforce where they're needed. To incentivize the workforce is always a strategy. That would involve things like increasing wages, but that's not everything. And providing travel pay to help get staff where you need them is really important. Covering housing costs, providing childcare. Those are things that people also need and that would incentivize them to work in areas where they may not currently work. And then finally, a strategy would be to provide wellness and behavioral health support for those who are working, for those who are considering going back to work, to provide on-site counseling, employee assistance counseling, and things like that. And then finally, my other colleagues on the panel have talked about this, but PPE, it's as critical. Staff don't have the equipment they need in all cases, and frankly, they're scared. So increasing access to PPE by ramping up and providing PPE, and then in the future, becoming much better prepared when these kinds of events occur. So the current situation has laid bare the problems in healthcare and actually, frankly, in our society pertaining to the provision of PPE, training health workforce, staffing, licensure, visas, and the deficiencies in our public health system because there hasn't been adequate support. Hopefully, others can help us on this panel, can help to solve some of those problems. Now I'll turn it over to my colleague, Bryony.
Thank you, Cheryl. And thank you, everybody, for being here. My name is Bryony Nguyen, and I'm the Chief Strategy Officer at Blue Cross here in North Carolina. Much of the focus on the supply chain over the last couple of weeks has been around physical things, predominantly PPE, increasingly drugs. When you zoom out, a lot of the healthcare supply chain, and Cheryl touched on this, is actual human beings. And when you think about that from a health plan or from a payer perspective, we pay those people who are providing those services. And so I want to start here with the human front to say thank you to all of the people on the front lines who are working during this crisis. And then let's take a step back and talk about how, from my perspective, Blue Cross North Carolina, but more broadly, how those who pay across the supply chain are thinking about some of these broader supply chain issues during COVID-19. Very basically, we think of supply chain in terms of demand and supply. And on the demand side, we think about a member perspective. So let's start with that. The focus has been primarily on removing barriers, be they affordability barriers or cost barriers, or frankly, technological barriers for care. On the affordability side, we have seen many payers drop cost sharing for any COVID-19 testing. And then beyond that, removing the cost barriers for treatment as well. Blue Cross North Carolina is among them, but that has removed a big barrier for members on the demand side. On an access perspective, you've also seen, clearly a lot more people wanting to receive care from home and frankly needing to for social distancing requirements. Our telehealth searches on payer websites on the Blue Cross website has gone up 100-fold over this time. And so you will see that many payers have pivoted to cover telehealth, and not even in the previously more restricted way, but even a phone call we're paying currently during this crisis at the same rates as you would have paid for an in-person visit previously. And this is parity for appointments with primary care providers, with specialists, with behavioral health providers, any North Carolina licensed provider who can provide services over video or over telephone. Couple of stats for you on the telehealth webpage. Typically, we get 1,000 to 1,500 views a month. In March, it was more than 12,000. On the behavioral health aspect, and this is mental health and substance use, a McKinsey report recently found that 78% of North Carolina respondents reported experience moderate or high levels of distress related to COVID-19. This is an exceptionally high number for an issue that people don't typically talk about. This is usually underreported. So if we think about it's even at parity or slightly underreported here, that is 78% of people. This will be a supply chain issue today in terms of trained and licensed behavioral health specialists, counselors, community peer support workers. But this is also one we should plan for and expect to go on for quite some time. Looking at the supply side of the chain, and clearly, I think the NIAC talked really comprehensively about some of the what I call widget supply chain concerns. There are also the human supply chain concerns as well. So in terms of cost barriers here, providers face a possible cash crunch here. And for folks who are not part of this industry, it seems a little counterintuitive because people are seeking more care because of COVID, but it's not. We are, a whole bunch of care is being deferred, either elective care or care that can be deferred. Think things like hip replacements, knee replacements. We're speeding up claims payments as part of the response to this. Typically, there's a 30-day claims payment lag. We've put measures in place at Blue Cross North Carolina, and I think you'll see this across many payers, including government payers. But we've put measures in place to pay 90% of these claims within 14 days, and a significant proportion will be paid in 7 days or less. We're also reimbursing in and out of network providers directly if a member's diagnosed with COVID-19. Think about it that for any self-pay part of provider treatment, providers typically receive 94 cents on the dollar. They are now getting 100 cents on the dollar from the payer for that. So that's a little bit to help with the liquidity issues we see in the supply chain for providers. There are a set of administrative barriers. Typically, insurers have taken steps, including us, of not requiring prior approval for medically necessary services during this time. We have recently suspended many of the administrative requirements, such as prior auth for acute inpatient hospitalization during the 2-week period that North Carolina expects a surge. And I think Cheryl, talked about this at length, but the workforce barriers are real. Payers can help credentialed physicians, physician assistants, other clinical staff by credentialing them much quicker. And so we've made a commitment to do that within 72 hours. Expanded telehealth, I talked about, folds in here. Paying at parity is a massive step to support this. And then, on a more close to home level, we have offered 2 weeks of paid leave to any clinical staff, employees at Blue Cross, who would like to volunteer their time supporting hospitals and practices during the surge. Finally, I think we need to talk about and at least begin the conversation on a broader health supply chain versus just healthcare supply chain. It was reported yesterday that 540,000 people in North Carolina have filed for unemployment benefits in less than a month. Accommodation, food services, retail account for 42% of jobs across the US economy. And these are jobs that are pretty much dormant currently. And over a quarter of North Carolinians have reported relying on community-based organizations or government-assisted assistance for food, which is, problematic from a health perspective and limits their ability to stock up for physical distancing or self-isolation, and so can, create a perpetual cycle of COVID. I don't think we have the answers to all of this yet, but I do think that we need to start having a much more serious conversation about the supply chain of food in relation to health and healthcare more broadly. I think what has come out in everything that everyone has said today, and certainly we've seen, is collaboration in the time of crisis is essential. If it wasn't apparent before, it certainly is now that the global system, we are so deeply interconnected, and that is, COVID highlights that just from the contraction of the disease. This interconnectedness is very much true at the healthcare supply chain level as well. And we have seen collaboration in a way that somebody previously to this would have said is impossible. Suspending the workforce barriers, ramping up telehealth, these are things that were estimated to take years to do and have happened in a matter of weeks. And I think as we think about innovation and collaboration across the system in general, we need to think about what we've been able to do now and take it forward in non-crisis times. I will hand it over to Mackenzie now.
Thank you so much, Bryony, and thank you to all of our panelists for sharing those thoughts. Sorry, I'm getting some feedback. I hope that y'all can hear me okay. We are now opening things up for Q&A. As I mentioned at the top of the call, for anyone joining us via webinar, you are welcome to submit your questions via the Q&A function at the bottom of your screen. For reporters who are joining us by phone, you can submit your questions directly to me via email. That's mackenzie_babb@keenanflagler.unc.edu. So our first question today is from Celeste Gracia. Professor Deshpande mentioned 4 ways to utilize PPE more effectively, including reusing PPE and creating supply from existing resources. Duke Health has developed a way to sanitize mass amounts of N95 masks. Duke, UNC, and NC State are using 3D printers to produce face shields for healthcare workers. Are these efforts enough, and how long are these kinds of efforts sustainable? So, Vinayak, I don't know if you want to kick things off there. Others may have thoughts to add as well.
Sure. So, quick short answer is this enough? And the answer is obviously not. I think we need to do more. But these are definitely measures that are needed that fills in the gap right now that we have in PPE. Yeah, but obviously, in the long term, we'll need to do much more than these measures that we have. Maybe others want to chime in on that.
So I think you said it really well, Vinayak. So to think about this is a stopgap approach. We are trying to make best use of whatever we've got, and we are buying ourselves some time in this process. Because as I said earlier on, the ramp up time and the lead times for these to kind of come up to the volume productions that we want them to be coming up to, it is going to take a while. So these are good stopgap measures, but really we want to get to a position where we have 3, 4, 5 times what we are producing already in our global supply chains and being able to have that in the US. So, and that's not going to happen overnight. That's going to be at least a few months for sure.
Definitely. Thank you, Vinayak. Thank you, Jay. Our next question comes from a researcher who's wondering about a vaccine. I love this question. It's so hopeful. Once a vaccine is approved, what do you recommend as the best way to get vaccines to the public? do you foresee any challenges in distributing and in supply chains related to vaccine dispersal?
I'm happy to start, and others can jump in. So I think a key question will be how it gets distributed. Most people probably don't spend a lot of time thinking about the way vaccines go out, but they can go through kind of more traditional private channels. But the government actually sources a great deal of vaccines and distributes a great deal of vaccines. Kind of children's vaccines is a good example of programs that they run. And so I think that the system is probably well prepared to distribute. The key question is going to be an allocation one. I think as we look at these, and so this is tied obviously to Jay's work, that initially much of the vaccine is going to go to the highest risk populations, thinking about frontline medical personnel, thinking of the folks who have kind of comorbidities, the elderly, and so how that cascades out. And I think that's a piece. It's not going to be just flipping a switch and suddenly we all have the vaccine. It's that we'll have a little bit vaccine and then a little bit more as we scale it. And I think the other piece to realize with vaccines from talking to folks who make and distribute is, these are extraordinarily tricky things to manufacture. So even with kind of full resources behind them, it's going to be a great deal of work to scale this up to capacity to serve, a state, a country, and the entire world.
Great, thank you, Brad. Next question is on future flare-ups. So how will hospitals and other healthcare systems prepare for future flare-ups? We know this is kind of a once in a generation, we hope, but knowing something like this could come again, will we see a more efficient supply chain moving forward? Jay, maybe you want to kick this off?
Sure. I think in my own opinion, this will fundamentally shake some of the pillars on which our healthcare system has been built so far. And one of them has been to try to run hospitals and important activities within hospitals on very low inventory, just in time, shoestring kind of resources. That's one thing that's going to change in a big way. The other thing that's going to change in a big way is how the public and the private enterprises work together for concerns related to public health. And I think right now we have these two quite separate entities. If you look at emerging countries where developing nations where they think about public health, there's a lot of public-private cooperation that is happening. And I think that's going to be another big change, in my own opinion, as we think about hospitals in this country.
Great. Excellent. Our next question is probably one that we may have Bryony and Cheryl start off with, but it's about the temporary cancellation of elective procedures. What's the impact of that on hospitals' ability to pay their nurses, doctors, and staff?
Yeah, I'm happy to start off there. I think it is definitely having an impact on the hospital's current cash flows. How much or how little, I think, depends very much on the level of cancelled procedures and where you are. And, the sense of how quickly hospitals think this demand will spring back post-social distancing, because they can carry themselves for a certain amount of time. I think this will have particularly troubling effect in rural areas. And, we have already hospitals who are under extreme financial pressure in rural North Carolina. The other place I think it's going to have a problematic effect is in smaller, more private primary care practices, for example, or the small business sector of our provider landscape.
I'll jump in very quickly and just say, Bryony's hit on some really important points. I think the other thing we've seen come about is the need to really ramp up, you touched on this, Bryony, ramp up and scale up telehealth. It's been pretty amazing to see how that has kind of rallied the health workforce and is getting them to think about providing care in different ways. I suspect that will continue. And honestly, I think that's not a bad thing in some ways. And I think also thinking about the innovations that could come to bear because we're thinking of delivering care in other ways besides face-to-face or person-to-person. I think it really opens up another world for us potentially.
That's great. Thank you so much, both of you. Next question is probably best kicked off by you, Brad. It's about moving forward. You know, we've talked a bit about hospitals lacking the necessary supplies to deal with a crisis of this magnitude, and it's a rare occurrence. How can hospitals moving forward strike the right balance of being prepared but also not stockpiling?
It's a great question. I mean, I think in some ways this ties back to Jay's point, right? This is always the trade-offs that any organization is trying to make, right? And what do they think the future is going to look like, and how do they prepare themselves to respond to that? And as Jay said, and Vinayak mentioned this too, there's been the push to kind of more and more leanness. And you see this not just in healthcare, across businesses all across the spectrum. I think the struggle that we'll see is this sort of tail risk that we talk about of extreme outcomes. I think what we might be starting to appreciate is these extreme outcomes aren't that extreme. I certainly hope that we won't see a coronavirus outbreak like this again. But as we dig deeper, we appreciate, well, other things are going to happen. And so having increasingly brittle supply chains and operations are problematic. How can we think about redundant capacity? How can we think about supply relationships that will allow us to be nimble and agile? And so I think we'll see a lot more on agility versus leanness as we move forward.
That's great, Brad. Thank you. Our next question is for you, Cheryl. Once the immediate crisis is over, what changes do you think need to be made to healthcare personnel policy?
Okay, thank you. I think Brad just ended on the word agility. And I think that's agility and flexibility, the ability to be able to get people where you need them. So it's going to be, and within organizations, so within hospitals, for example, getting people in the units and the sites where we know patients will be coming in, the emergency room, intensive care, things like that. It's also going to be having a supply and the availability of people who can come into work. So, for example, being able to use contract staff, and some of this is at the organization level, and some of it's more like a state policy level. But at an organizational level, being able to have staff who work, we call them per diem in healthcare, but it's as needed, so that you can call in people to work in certain areas. It's also having a plan in place to be able to train up people as you need to. It's thinking more broadly about the kinds of people who might be brought in under these kinds of circumstances. So, for example, there aren't many licensed practical nurses employed in hospitals, but that's not because there's nothing they can do in hospitals. It's because licensed practical nurses may help to provide certain things so that registered nurses are freed up to focus in the areas that they really need to focus on. So I think it's agility, flexibility, and then at a state level, it's thinking, and even national level, it's thinking through how to support people being more mobile. So, for example, so that we can get people to New York who need it, that currently can't get there. So whether it be to relax travel bans, whether it be to relax state restrictions, those are the kinds of things that we need as a flexible system that surrounds such events.
That's great, Cheryl. Thank you so much. Our next question is back to supply chains. Given that the supply chain is global and the crisis originated in China, what, if any, impact did the U.S.-China trade war have on our ability to respond quickly to the pandemic? and vice versa? What effect might this pandemic have on that kind of ongoing trade war?
So maybe I'll take a first cut at this. One can truly say that it did not help, right? Whether it hurt or not is not clear, but definitely it did not help us. Now, would it have helped if we had very good relationship? It is questionable because China itself was going through this crisis before we did, and they had already ramped up production of PPEs and other types of materials in their plants to satisfy the needs of individuals in China. So it is really not clear if having a better relationship, all of a sudden they would have given us a lot more than we asked for. Now, in the long run, it is very clear that in a global supply chain, if we have barriers, then it's going to make people suffer on all sides of the fence, right? So there is some suffering as a result of all these barriers on the Chinese side, and there's also a lot of suffering on our side and in Europe because of these trade barriers that are in place. Given global supply chains exist, I think trade should be freer today.
Great, thank you, Jay. Vinayak, were you going to add something?
Yeah, I was just going to add that, for example, the shortages of PPE is not the first time this has happened. So, for example, during the H1N1 pandemic, also we had shortages of PPE. And at that point in time, a lot of domestic manufacturers had ramped up their manufacturing of PPE. But then once that was gone, we again started sourcing from low-cost countries. And I think after COVID is done, I think we'll need to take a hard look at domestic manufacturing capacity and not be completely reliant on global trade to provide all of our sources of supply. So that might be a change that might come because of COVID-19.
Well, Vinayak, that answer leads right into what I think is going to be probably our final question, which is exactly on the manufacturing aspect. So question is submitted from another researcher. Does it make sense to have government policy that would guarantee manufacturers of PPEs reimbursement if early on we see a potential epidemic and have the need, but maybe over time the situation changes, the demand is not needed, but the manufacturers have ramped up early to provide the supply chain with what's needed kind of early on? What would your take be on that?
So Jay, you want to go on?
Okay, I'll take a shot at that. Well, basically what we are talking about, if I understand the question correctly, is the manufacturer is taking a risk in terms of ramping up production for PPE, an essential good for the economy. And once things become stable or we don't need them, how should we deal with the people who have taken the risk and invested in this? And the answer is, should government think about providing subsidies in these cases? The answer is yes, right? In order to encourage manufacturers, small-scale manufacturers to do this. Now, but one has to remember that things like this in the small scale work to some extent, but really the power is in the large-scale manufacturing. So we want company like a 3M or a Medtronic to triple, quintuple, quintuple, 6 times, 10 times, whatever the terms are, their capacities. Because that's really what is going to make it, fruitful, and that is what is going to lead to better health for everybody.
Excellent. Did anyone else have something to add on that? Nope, we're all good. Excellent. Well, like I said, I think that's the last question that we have time for. I know we're coming up right on the hour. I know we didn't get a chance to answer all of the questions that were shared. So if you would like to schedule a follow-up interview with any of our experts, you can reach out to me directly. I'll be happy to put you in touch. Thank you again to all of our experts for being here. Thank you all for participating and for your thoughtful questions. And we hope to see you again next week. We'll be meeting same time, same day, Tuesdays at 11. So go ahead and mark your calendars and hope you're able to join us again. Until then, take good care.